All right, Laura, it is I was going to say it is 11:04. It is 11:04 in
And it's
Washington.
4 after the
It's
hour.
it is 2:04. I know Ben is not going to join us today. But we'll go ahead and get us started as individuals are rolling in. So, welcome to everyone to our collaborative care special interest group, or SIG, as we like to call it. My name is Monica Harrison, licensed clinical social worker, clinical trainer, implementation coach with the AIM Center. And one of your leads for this collaborative care SIG, along with Ben Hillier, who is not here today. He's not joining us today, but he is the secretary for this group. And then Laura, who I'll let her introduce herself.
Hi, I'm Laura Sideri. I'm a general psychiatrist who works in integrated care settings clinically and then also provides technical consultation and medical directorship support for CFHA. I'm located geographically in New York, where I run blended collaborative care and PCBH programming and also work as a psychiatric consultant, and really, really excited for this conversation today. We've had a lot of nice lineups and snippets in our previous meetings from this year, having speakers come, talk, share their expertise. This is going to be really like a mashup, sharing with our brain trust here about what are your secrets and what do you want to know about sustainability for collaborative care model, how it works in the real world, how it works in the ideal world as well with fidelity. So this is going to be hopefully a really nice, engaging, and low pressure sort of conversation we're going to have today. Monica and I put together some key talking points that we have come up over and over again when we're working with teams that we can start with, but this is really one of those spaces that bring your questions, bring your thoughts. Monica, you want to kick us off with our
Yeah,
first
I
action item for
will.
discussion?
I will kick us off. I think just to add to what Laura was saying is sometimes, though, you all are hearing things out in the field. And you think you're alone in a silo, but you're not. And so if you are hearing things that others are coming into challenges with, you can feel free to bring that up as we pose these different topics. So you don't have to think we're thinking it's you. Sometimes I think we don't share as much because we feel like we're going to be called out and maybe we're doing it wrong. So just know that this is a safe space. This is not a punitive situation, but we wanted an opportunity to also spend time connecting with this group instead of always speakers. So our first one, around collaborative care, sustainability, and just considerations, is wondering what individuals are doing around caseload and caseload sizes. How are you balancing that and determining what those need to look like for your behavioral health care managers? So anyone who wants to go, what you're doing, or people you know, if you don't want to call it out for yourself.
And I can kick us off with just an observation. This is always really hard, I think, to get exactly right, because you don't want to have such a low case size that you can't be sustainable, especially if you're relying on revenue generation as a way and a means, and you've not broken into the value-based care space. And you also don't want to overwhelm your care managers. So what I've noticed is when we have pushed with my team to really get up to those optimal highest caseloads, if you push beyond that, you end up with a lot of patients that are not billable, that are on the registry, but are not actually engaged in care. So it can be a double-edged sword. And finding that nice in the middle is challenging. You ought to know when you're too low or when you're too high for those various things that are coming back at you. Molly, you put into the
Uh,
chat, we're starting CoCM alongside our PCBH program, which has been in existence for about 6 years. We are aiming for 100 cases per BHCM. You want to share a little bit more about how you arrived at that number, Molly, and other considerations or things you're learning or scared of, nervous with?
Oh, there's a where do I start now? We're in good hands. We have Daniela Hernandez, a CFHA consultant, alongside of us for this journey. So we arrived at the 100 utilizing some of the literature of best practices ranging between 80 to 120. Um, that is some of what's out there, what's on like the little blurbs. We don't know what we're gonna get, and that's I think like the thinking process behind this is like, well, we don't want to reach too high, but we also don't want to put ourselves too low. And we also know that the 100 cases aren't going to happen overnight, so we need a time period for our BHCMs to ramp up in that way. So that's what we're thinking. This is why I'm here. This is why I'm in the SIG group, is to glean knowledge and wisdom. We're not right now, it seems like that's what we're aiming for, but we don't know what we're gonna get. So this is that part where it's like, let's find out. We're in an area that's very robust with PCBH. We do have some CoCM in this area that has published some information. Again, fidelity to the model, question mark, because I'm not in those programs. So I think it's really interesting, being and navigating these different landscapes while still trying to hold on to institutional interests, but also fidelity to model. Um, yeah, I guess I'll leave it at that.
Thanks for sharing, Molly. That's really good insight. And Laura dropped in the chat that importance of getting consultation or collaborating with others, right? Like doing some of that. Laura, do you know how many caseloads, how many patients on caseload for your BHCM?
So we had originally started out, Molly, quite similar to you, where we had a target of 90 to 100. And we found by doing that when we crept up towards those higher level caseloads, it was not sustainable for the patient population we were serving. Now, I'll caveat that with, if you're doing like very defined, very targeted, these are like kind of the specific care needs that we're caring for, and that's all we're doing. I think that's feasible. My care population, it's really all comers with any depressive or anxiety spectrum diagnosis that will be continued to be cared for in the primary care setting. And we conceptualized for my team CoCM as a way to both serve for BHC, not having like a backlog of patients that are needing continuity, depression, anxiety needs for that 3 to 6 months, still focused, but a little bit longer term. But we still get a lot of kind of patients with high levels of medical comorbidity with psychiatric comorbidity. We don't have exclusionary diagnoses per se. So we end up with sometimes patients with bipolar spectrum disorder and an anxiety spectrum diagnosis, and others that are first episode major depression. So if you have a more like homogeneous, more defined care need, fewer defined interventions, I found that it's more feasible to get up to that 100. But if you're caring for like a more kind of spread out population, we found that actually somewhere right around 75 has been kind of the sweet spot for us. That being said, I don't think there's a problem with having a higher level, target to begin with, as long as you're looking at what's feasible there, and shooting for the moon sometimes is better than telling people, all right, we're going for 70, and then you're going lower. 60 was really the bottom level, though, where we could not break even below that just for staffing costs and other things. So that was part of how we set that 60 as the lower level. And I see Sean,
Gotcha.
you've got your hand up.
Yeah, I was going to say, Shanda, you want to share what your caseload size that you're going for is for your behavioral health care managers?
We'll chat out because I'm going to tell you and then I have a question myself. But so I'm at University of Wisconsin Health, and we have both pediatric and adult. And so in our adult world, we shoot for around 100. And in the pediatric world, we shoot for around 80. And that's because we've just found that like the peds folks need more, like more of that outcome building kind of stuff. And so that's been a little more that because they seem to need more outreach, there's a lot more minutes that have add up doing one that it's just becomes too much to have 100 kiddos on the thing. But I will say this is something I don't know if other people have struggled with. We have really struggled with here trying to determine that.
Hey, Shonda, are y'all hearing her well?
I'm having some trouble with the clarity
This is
too.
really good info. That's what I was like,
Yeah,
wait a minute.
I heard.
what?
So I heard what she said, but only because I know Shonda, and so while she's getting her headphones, I'll recap what she said thus far because I think she's getting ready to get into her question. So for their adult population, the caseloads are 100. For their pediatric population, the caseload is 80 because what they've noticed is that it's taking more. Working with the pediatric population is taking a little bit more probably of that behavioral health care manager time. And so 80 on a caseload is better than the 100 for adults based on that rationale and reason. All right.
Can you guys hear me now?
Yes.
Oh, good. Is that
Yeah.
better, Patty?
Yeah.
Okay.
It was just going in and out, like,
Sorry
just
about
air in
that.
the room.
Yeah. I know how that goes. Um, no, so, but the problem I think that we've been struggling with, is that I just left my brain. Give me one sec. Guys, today's not my day. I'm
It's
sorry.
okay. It's gonna come back. It's gonna come back.
It will come back.
I do think though what you mentioned about the pediatric population versus your adult population, I think that's a real thing. So like as we're talking about caseload sizes, when you look at the literature and you look at guidance and you look at what everybody's doing, that's why you see such variance, is because the population that you work with does really matter. If you have patients that are gonna need more care coordination or they're going to need more collaboration with other individuals as a part of the clinical team, that is going to take more time. And so you do have to consider that when you're looking at caseloads. I will say when I was at Hartford Healthcare, ours was 72, which almost sounds like, why 72 and not 75, right? Like what is that? But ours was 72. And like to start off with, like we used a financial modeling workbook to kind of plug in people's salary and time and some of that. And we spent the first 2 months with our behavioral health care managers doing the work to kind of see like how much time are you actually spending doing this, doing that. So we started to then fine tune that to get to our number of where we knew we needed to be just to break even, right? Like that was our thing. So 72 is the break even. So when you start talking about like sustainability long term and other things you want to add to the program, and do you want to have a collaborative care lead person, and all of these other things that as you talk to other organizations, they're incorporating shared responsibility and all of this. There's still like there's a cost to that you also have to consider. But I think that's why you also see this range in what the caseload size looks like based on the acuity of the patients, the population that you're working with, and then also the structure of your collaborative care program, I think really matters. Shanda, you came back?
Yeah, you stalled beautifully. Thank you, Monica. So, so I was gonna say, what does everyone do when you are starting to get too many referrals? Because that's the thing we've ran into, right? We've had some of my adult providers have panels as high as 150. And exactly what Laura was saying is what pans out, right? Like they get so overloaded, you can't get people in back end when you need them to because there's no slots available. And it's not the you drift from model fidelity when you have a panel that high. And I've kind of always come from the ethos that we never turn off referrals. Like we never just say we're not taking referrals because I feel like that is a dagger in the heart of collaborative care. Like it makes it so that they don't trust you anymore. People don't, then it's hard to get the referrals back up and running. And like, I just never want to do that. So I'm curious what folks do in really busy times when things do get really busy. You guys hire Laura. Can you come talk to my folks?
Laura, you are thinking what I was thinking. I'm like, well, if you are looking
Business
at your
case.
Yeah, I mean, like you're looking at your registry, like sometimes when we think about the registry, we think about the registry as only a use for looking at the patient outcomes, but it actually gives you a lot of clinical guidance for your program too. And so if you're seeing that your behavioral health care managers are starting to be maxed and providers are sending more referrals and you don't have room and you all are looking at your ecosystem of who else in the community, how else can we plug these patients in to get what they need, it sounds like you need more behavioral health care managers. And I know in some systems, people are having their behavioral health care managers wear dual roles or dual hats, or like do PCBH and collaborative care. And so even if that's the situation and you're starting to see like, oh, referrals are coming in but we cannot stay on top of it, it's maybe time to start thinking about some restructuring of roles and responsibilities and hiring. um, yeah, I mean, you have the data and the evidence there to show if you're still taking these the referrals that are coming in, if those are still coming to you, so you're able to show like, hey, our behavioral health care managers are capped out. Here's how many more referrals are still coming in, and that's even with a hopefully robust panel of patients that are in, like that relapse prevention phase and getting ready to have their episode closed and new ones coming on, and you're still maxed out. What does anybody else do? How do you then take that and advocate maybe to C-suite that you need to hire more people? Anybody? Nobody advocates for more people?
We have it built into our pro forma. So we know when we get to 70 patients across all of the care managers, like our target is 75, but when we get to 70, or if we got new PCPs coming in, we know roughly kind of from our data how many PCPs can be supported by our care managers, or if we're going into a new site. We use that data that we've collaboratively formed already with our administration, so that it's not even like a conversation. It's all right, so those metrics have been met, now we're going to post and hire. So it's building those relationships. It's less about what that number is, it's more about having that relationship and making that business case. We're used to making the clinical case. All of us really get a lot of great training on that, but I can say as a physician, I was not given really great training on how do I have a conversation that's relevant and makes the business case to my CFO and CEO and COO. It's a totally different conversation than trying to persuade and get buy-in with a clinician compared to your C-suite. But both are built on relationships, and it's better to have those in place and kind of know these are sort of what I'm going to be looking for program growth or not thereof. Maybe they're like, nope, we want you to make use of whatever you've got. Totally different conversation and business plan if that's going to be the case for your team.
And I think we should be realistic about the fact that that is the case for some teams where they say like you have the number that you have and that's kind of it. We're not looking to expand beyond that anytime soon. Sometimes that is the case. And then you're having to figure out so that you don't lose or have then behavioral health care managers that are burnt out because their caseloads are so high and they're not feeling fulfilled in their roles, you do then have to really make some tough decisions. I will say I've been in a situation where we've had to make some tough decisions and not just take any and everybody that was referred to us. We had made a lot of relationships with community partners and other services that we knew some of our patients could benefit from and use, because we do still want our patients to get what they need, and at the same time, we also had to recognize our limitations based on some of the guidelines that was given to us. But I will say, I think the business case is something that we don't always think about when we think about getting the program going, but we're not thinking in advance, what is it going to look like for sustainability down the road? And so when you think about at your healthcare organizations, how do they determine when they need to hire new PCPs? Have we sat and talked with practice administrators or anyone in C-suite around what they utilize to determine that? So at least then when I'm going to make this business case, I can at least align it with practices we maybe already have in place. Where are those places that I can connect to some language that is already understood about how the business for my organization is done. Because they have it, they know when they need to hire new people, and it's not always just when someone resigns or leaves. Okay, so Shanda says we do ratio of total clinic patient panel and to behavioral health care manager.
So you're looking at the panel of patients versus, as opposed to the number of provider to provider. Is that what you're saying? Would you share your patient panel to BHCM?
Well, so it's different for peds and adult, and we're actually in the process of changing it right now. So, it was 1,500 patients. Well, I should nope, sorry. It was 1,500 patients with an anxiety or depression diagnosis per BHC on the problem list, or 4,000. Nope, we changed it. 6,000 patients to one BHC. So many of our clinics have around like 12,000 total patients, and so then we have around 2 BHCs in most of our clinics.
And the difference are adults versus kids?
Yeah, the kids is a higher ratio because I think, probably wrongly assumed we would need less BHCs for children because they have a lower incident of mental health diagnoses. And then COVID hit. So we've actually needed to increase the number of pediatric providers that we have. And that also, I think, lends itself to, we also had to lower the number of total panel patients for our pediatric BHCs. We call them BHCs.
I think this kind of also goes into another topic that was brought up, to just so those of you who are jumping on know, we aren't bringing these things up randomly. These are things that have actually come to us. And so we figured we would bring it to the collective here. Another thing that came up from someone, I think this kind of goes into some of this, is how do you leverage champions to advocate with you for your collaborative care service? How do you find these individuals? Where are they at? Um, you know, Molly, was it Molly? Someone was like, "Well, Laura, can you come and talk to my people to get me?" Or no, it was for Shanda. Like, come and talk to my people so we can hire some new people. Like, how do you leverage champions to help advocate and be in the good fight, as they say, with you?
Is that a question you
Yeah,
for
yeah.
anyone? We've been, I'm Stacy from Maine Health, and we've been talking about CoCM and working on this for years. And I'm excited to say that we started 2 months ago.
Yay.
And Maria Rotop, who's here, is our BHCM. And so we're learning more as we get going. But what we did early on is we identified a provider champion in the practice where we're trialing this, who's just really been a champion overall and really has partnered with us well on other things over the years. And he graciously offered to do this with us. So as we were planning and working on things, we pulled him in right away. And so he has sort of grown with us as we've learned and started this adventure. And so he's part of our implementation meetings. He's anytime we're trying to work out something related to Epic, we check with him about it. Like we involve him in like so many of the conversations and decision making. And so then he is the representative, but then he also takes some of the discussion and brings it to his provider meetings, shares the input with the team. He's the liaison between us and them and partners closely with Maria on things. So we've he's just been willing to be there and with us along the way. And it's been so critical because he speaks the language. And sometimes we think of ideas and we're like, oh, that's brilliant. And we talk to him and he's like, no, that won't work. So important to have that role as we're learning and just helpful to help us get it off the ground and just like be the voice.
Yeah, so I hear when you say like, well, he learned with us. I love that, right? Like, so he's in there too to say, yeah, well, here's how this could work, or, oh, that's a new idea. I hadn't thought about that. And he would know then how to best um, reciprocate that language or using the right language to discuss the process with other colleagues. Did you feel like you had to twist your arm initially to be like, hey, come here about this awesome thing? Or was he already interested?
He is already interested in so much like behavioral health stuff. He has had a lot on his plate, so I think initially he was a little bit like, oh, not sure I'll be able to really devote the time. But when we talked about like how it's just a different approach and a little bit of a game changer for some of the patients in the population, like just the different approach to it all, he was excited and so like jumped right in.
Gotcha. Okay. How's anyone else leverage finding a champion, whether it's in your own clinic or if you're working with a system and needing to find champion providers or even a champion. Sometimes it's hard to find a champion behavioral health person, especially if you're doing multiple roles and you're trying to tell someone like, hey, I know you're used to doing this psychotherapy billing thing, and I'd like for you to come over here and do collaborative care. That could be a change too.
Yeah, champions can be found anywhere. So I think we underestimate like a front desk champion can have huge amounts of buy-in and like kind of explaining the program and you know the care model to patients. Nursing champions, you know, PCP champions, behavioral health and psychiatric champions. And it's different than like just showing up at the meeting. So I've had some champions that don't understand like you do have to sell
Mm,
what we're doing, even if you don't agree with like kind of those different pieces of some of the exact pieces of the workflow, like Stacy described your champion, you know, I have a different way of looking at it, but we all are aligned that like collaborative care is what we want for our patients. And so I've had experiences where you have a total difference in uptake, fewer, you know, PCPs at one clinic, but huge amounts of uptake, lots of PCPs, but like terrible uptake. And what we see in the diamond studies plays out in real life, that true championship, meaning like you are backing, you're saying this is what we want, is what's needed. At one of the sites, one of the PCPs at every meeting, she was supposed to be the champion, was saying, oh, well, our patients just don't like telehealth. And our patients don't like doing the screeners. And the providers don't like doing this. So was showing up at all the meetings, was checking the box, but not actually like championing what we were all trying to do. And in fact, like eventually came to light, was really had like a co-located psychiatrist that wanted to bring into the setting. So there was a conflict of interest in terms of the provider champion role. And at the other side, we had some of the strongest champions be in front desk and be in nursing and came up with great workflow ideas. We're identifying, we have one building that's got 3 floors, and there's concerns with how do we have, if somebody's violent or acutely agitated, how are we going to address that need in that sort of space? And front desk champion was like, this is what I'm noticing in the front desk. Nursing champions like, this is what's happening in triage. So don't underestimate the power of champions at every level. And it's anybody who's wanting to be there and show up and advocate for that model, even if they're maybe like not agreeing fully on all the different pieces of the workflow and how exactly we're executing it.
yeah, Daniela put in the chat, don't underestimate the MA champion. Yeah, like I'm seeing more and more just innovative things being done in nursing home facilities and all of these types of just arenas of healthcare. And it is involving a thinking out the box of who your champions are, who you're bringing to the table for conversation, as you're thinking about rolling out, as you're thinking about implementation, as you're thinking about workflows, like the whole nine, which also kind of goes into the comment that you made, Molly, around needing champions in kind of the legal and regulatory areas of this as well. I think is really important. And I think we're seeing more and more happen on the advocacy front, not just within our organizations, but also in our states, around codes and all of that. Hence why Colorado, you all missed it, who got on a little bit late. We were talking with Gabby, who's joining us new from Colorado, whose codes are on as of July, I believe, as of, yeah, this month, who got their codes turned on as of this month. And so I'm like, yes, for Colorado. And we're hearing more and more, right, around the states. Sometimes the reimbursement is amazing. Sometimes it's like, all right. And sometimes it's like, what do you think we're going to do with this? So there's the gamut of that, right? And still advocacy that needs to happen often, even after codes and things have been turned on, but definitely needing those champions across the board in many different sectors. Totally in agreement.
I think IT people are also like not to be underestimated. They've been so helpful, and like we were just putting together a workflow for like suicide care management, and like we are in Athena if anyone else is using that, but which has really not historically been built for behavioral health. And so we have several people in our IT department who have been so helpful and so interested in making sure that we can develop those workflows, and also connect us to meetings that like we would otherwise not be in, to share that and make sure that directors of our outpatient clinics know, and that all of that this information is being spread. And they're just such a wealth of knowledge. I love our IT team. And Stacy, did you say you were from Maine? Okay, I am also from Maine. I'm in Colorado now, but I love meeting a fellow Mainer.
Nice. Nice to meet you, Gabby.
You too.
And I totally agree with what you're saying too. Like it blew me away, the team that assembled to help us when we were ready to actually take off. It was made up of billing people, IT people. It blew me away. Like the people that came to the table to help build this for us. I just can't say enough. And we still, right, Maria, I mean, we have them on speed dial, like, hey, this isn't working, but they're so responsive and just have been instrumental to making this work. So there are definitely champions everywhere.
Mhm.
When you find them, it's amazing.
Yeah. Take them and be like, you're coming with me. Not too hard, but you're coming with me along the
Yeah.
way.
Yeah.
There was a question, Patty, are you asking about other payers other than Colorado Medicaid? And I do think, Gabby, was it July 1st or is it later here in July that it turned? I know it's July, but I
Yeah, I
couldn't
believe
remember.
the first.
The
Yep.
first. Okay. So yeah, so Medicaid in Colorado turned it on July 1st. Or I say turned it on because that's just the terminology we use, but turned on the codes in July 1st. I'm not sure right now about other payers. When you say other payers, are you talking other states? Or are you talking
In
about
Colorado.
commercial? Oh, in
Does
Colorado.
that mean in Colorado, all the payers are paying?
For Medicaid, as far as I know.
Well,
But
yeah,
yeah.
commercial or all of your commercial payers in Colorado, as well as Medicare and Medicaid.
Gotcha. So some of the commercial payers. Anyone on the call familiar with the commercial payers in Colorado and what they're doing?
And this is Patty's area of expertise. So she's a great person to have share about those pieces if you're not sure, or if payers aren't, providing coverage.
Yeah, I'm not sure. I'm only familiar with Medicaid doing it, but I think there's someone else from Colorado in here too, so I don't know if they would know.
We still haven't gotten our Medicaid codes turned on in Arkansas. And one of the things we're looking at, what are the things that will convince? We were told yesterday, some people you just cannot convince with facts, kind of like stages of change. And one of the other things I'd heard that could be a barrier is that a lot of, especially a lot in Arkansas, a lot of the traditional Medicaid are children. And so how does the data stack up for cost savings for children? Or is it that the value for children is more about access, quick access, and helping the PCBs? That's ends with a question mark.
I will kick off some response. Just want to say that Stacy said that you're not alone, that Maine Medicaid is still not reimbursing as well. I will say when I was I'm now in North Carolina, who is reimbursing at a great rate, and there's a big push happening. Also, big plug for the conference this year is in Raleigh, North Carolina. Registration is open, so if you haven't registered already, please register for the conference. However, before coming to North Carolina, I was in Connecticut, where they are reimbursing the codes now, but at the time I was there, they were not. It really took advocating with other healthcare systems, and this is where things sometimes would get dicey. I'm not going to say which healthcare systems because there's more than one. I worked for the large one, but there was more than one there. But it really took collaborating with them because our voice was much louder when we were together talking about what we needed and why. And the way we actually got it through, Connecticut doesn't play about their kids. Now I'll give them that. Like they are not playing about their kids and kids' behavioral health. There were a couple of situations happened where some adolescents had committed suicide, and actually there were some that weren't, they were like pre-adolescent. And so there was this big momentum push from a legislative standpoint of what are we doing for our kids? What are we doing for our kids? And a bill was created and collaborative care was tacked into that. So no matter how you might feel about politics, because I am not here to talk to you about politics, but what I am here to let you know, whether it's politics or whether it's your organization that has certain metrics they're looking at, sometimes your way into something and getting to do something is to tack on to something else, right? To where it fits. Had we gone in there and just started talking about just the adult population and collaborative care, it might not have moved as fast. It probably would have taken much longer. But kids was the thing. They were wanting to really protect their kids, and this bill came up, and we're like, oh, collaborative care. And that's where the conversation had started before, but it was almost like 51st dates with some individuals in legislation. But when that happened, and we were able to talk about the business case for how can we help with getting access to availability for, right, like these services wrap around, it's a team, all of this, then that changed the thought process for a lot of those individuals who make those decision makers, who make those decisions, and it was able to pass and get through. And so I see that also happen when individuals are working in clinics that they want to implement collaborative care and they feel like there are these roadblocks or people just don't get it. And sometimes the spirit of collaborative care is where we need to approach from. And so, are you having a big push as a FQHC on working on patients' A1Cs, and you all need to get those down because you're looking at these dashboards and that's what the organization is focused on from a quality metric standpoint? Then let me talk to you about that connection between depression and diabetes. And then here's what we could do with collaborative care. Like, how do I fit into what the system is currently focused on and trying to work on? How do I fit with that? Sometimes that's the way in, and then they see you're great, and then they're like, well, what else can you do? And then you just open up everything else.
Thanks.
Absolutely. So Lori, you're dropping some nuggets here for us in the chat. What you dropping in here?
I'm learning too. So this is an area that for pediatric collaborative care, the sort of return on investment piece, I've not been aware of as much. The first one is a meta-analysis that includes, but is not limited to, CoCM. Kids and young people with ongoing conditions report greater cost savings in most of the studies that were reviewed in the meta-analysis, but there's some quality and reporting challenges with the quality of the studies. And it looks like in kids with chronic or complex medical conditions, IBH and care coordination supports have been associated with reductions in ER visits and inpatient utilization, with medical cost savings exceeding program costs in some Medicaid populations. So that's a similar finding we see for adults. There's one other study here that I'll drop in that did not show consistent cost reduction looking at just the immediate variables, but when looking at broader societal costs, that value-based argument changed. So if we think about what is the value of reducing progression to severe mental illness when somebody is 12 compared to when they are 50, I think that's where the argument can get more compelling, especially if we can capture some of that data.
Gotcha. Yeah, I heard someone today asking a question about for younger kids and Z codes. And is this a situation where Z codes would be reimbursed by collaborative care? There was not an answer for it, but they were doing some fact finding around that and going to be bringing it back. Chanel or Christina, can you talk to us about what is the bloated billionaire bill?
Otherwise known as the Big Beautiful Bill, HR1, the whole disaster of cutting Medicaid and, basically letting people die so billionaires can have tax cuts. I'm super mad today.
Well, thank you for owning your feelings, because those are your feelings and you have a right. Okay, so in Washington, I'm guessing yes. Okay, so in Washington, did the
No,
bill pass or
Washington
the
State.
bill's on the table?
I thought you meant like Washington, D.C. This is a Washington, D.C. thing. This is like the whole country is losing Medicaid
Oh, gotcha.
funding. So like if everybody loses Medicaid, then what happens to all of us as a general rule?
I just posted because that's something my team has been asking about as well.
Gotcha. So concerns from teams, rightfully so, about what is going to happen if we lose Medicaid. What do we do for a majority population of our patients who are utilizing our services? How are you answering that?
This is where, for my team, we're really trying to get more into the value-based care space, because there's this great expanding body of evidence that's showing cost savings at the healthcare system level with reduced ER visits, reduced hospitalizations, improved physical health outcomes. And so it's important, if we can make sure we understand all of the needs of the healthcare system, we can match that value-based argument to them. Right now, my perform is built very much heavily on fee-for-service generation, not really tapped into the value-based payment, but that's something that I'm looking for my team. What data can I mine related to hospitalization, higher level utilization costs, HEDIS measures, MIPS? What can we're going to have to beg, borrow, and steal some of the data points that maybe we're not accessing right now, where we've been able to make the business case for it with fee-for-service generation. But I'm concerned too, although it's a state-by-state impact with some of the decisions about Medicaid, a lot of the federal funding is going to then trickle down impact into our states as well.
Anyone else talking with their staff about this? I do agree, Laura, around HEDIS measures and MIPS, like some of that. I think we don't always do as good of a job at looking at how what we're doing with collaborative care is impacting other medical conditions, right? To start to have, especially we're in healthcare organizations, to start to have some conversation about the impact on other health conditions, not just behavioral health conditions, and what that's looking like. I do think that that is important. How's anyone else talking to, if your staff is concerned? Um, or they might be like me, get so tired of watching the news. But if your staff is concerned, just like what does that mean for them and job security, workforce, security? How are you addressing that? I think it is a real concern. Mm, yeah. So Gabby is mentioning some of the resources that are out there that help our patients with medications, with co-pays, with all kinds of other services sometimes that they need, and how we will continue to be able to help in those arenas when some of the funding takes away these programs and services that are out there to assist. I don't know that I necessarily, Gabby, have a answer to that, other than just like it is a real, we could be in a real resource deficit and end up having patients who become sicker.
Has any of you that have been doing it, what are your primary care clinicians saying? Why do they want it? What's it bring to them?
Do you mean collaborative care in general?
Yeah. And
That's such an interesting question because just before this meeting, I was in a team meeting with my other fellow care managers, and one of the things that we were revisiting was sort of the scope and role of what we do, because we're still always trying to really kind of adapt it to what we need here in our clinic setting. We have a lot of clinic locations, and so there's about 12 of us so far, and everybody has slightly different very different constellations of providers and patient caseloads and all of that. And one of the things that I think we tend to overlook is that impact that we have with the PCPs, that we are, I made it like an asynchronous version of the psychiatrist, us, the patient, and the doctor all sitting in a room trying to figure out how to get the patient better. And that without us, the PCPs don't necessarily have that piece and that knowledge, and that I mean, they have the knowledge, but they might not have the time even to address everything that's going on with the patient. And so to them, there's a huge value of us being able to help make their work possible in a consultant almost way.
Yeah. Anyone else have
Great
feedback
answer.
from I will say we've been doing a behavioral health learning community for just behavioral health care managers that are implementing collaborative care directly. Some are wearing dual hats also in the leadership role, but everyone that typically comes is providing services directly. And they have completely, some of the feedback that we've gotten is they have completely enjoyed being in community with one another and not feeling like they're in this silo, which I think is also the thing with collaborative care. Like, yes, you're working on these behavioral health conditions and concerns that are coming up, but you're working on it as a part of a team. There's not this lesser than feeling that I think in some instances, some may feel when they're working in a healthcare organization, with the hierarchy of your medical providers being the ones that make all the rules, and kind of it is what it is, and what they say kind of goes. I've not heard from the behavioral health care managers that feeling. They really do feel connected to the work and to the team that they're on, which I think is really important, just for that kind of internal give back, that internal satisfaction for them. And it's very different than working in the outpatient world. I've done both, and it is just a different lens that you take. You usually do feel very much like an outsider when you first come in. And you're like, why aren't we doing, like, why are y'all doing that? Trying to understand the health arena when you come from behavioral health, I think, is a challenge all by itself. But when you get to this spot where it's like, no, it's not just you, it is a team of you. It's not just you who's responsible for this patient, or the behavioral health care manager, or the PCP, I think has been a valued benefit. And of course, we have the research that's out there around PCPs feeling like that burden is lifted, that they have to fix this patient, and they have, support, which gives them more job satisfaction, and retaining your providers. Yeah, Daniela. Yeah, you do have to experience it for sure to really understand the benefit of it. I remember when I first started just talking about integrated care in general, because I actually started in the PCBH world, and I would talk about what I do in integrated care, and people would be like, "Yeah, that makes so much sense." Like, it makes sense. Everybody's always like, "Yeah, that makes so much sense." But then it's now how do you actually do it? Like, how do you do it and make it work, and make it sustainable?
And it's funny you mentioned that, Monica, because in my experience with some providers, I won't generalize here, but it seems to me that providers listen to my spiel, my dog and pony show, and then they automatically think, oh, it's more clicks. It's something else on it. They think of it as a burden versus a load,
Mhm.
unburdening them with support. And until they experience something with that one patient that always sucks up their time, then we get the true buy-in.
Yeah, absolutely. I always have said to other individuals when they ask, like, what do I do about the provider that never wants to refer, that never sending us patients, that never is listening to us, da da da. I said, don't put so much energy into that provider. Focus on the providers who do want to do the work, who are interested, because they will eventually be the ones that are your advertisement, your free advertisement or mouthpiece for the other providers who aren't so much on board.
The value of the PCP champion. You know, we could be
Going back to the
sitting
value of the
there as
champions.
the outsiders, mental health professionals saying, "Oh, collaborative care, it's so helpful," but nothing is like hearing it from one of your buddies. And sometimes it gets a little bit competitive. Like, "Oh, we got this person who's the top requester for services." So doing some kudos and shout outs and really highlighting the successes can sometimes generate a little friendly competition and excitement too. So yeah, having that internal buy-in is just can't speak to that enough.
Yeah. And so someone also put in the chat, and I'll close with this, Laura. Not even for the provider who doesn't want to refer, but also maybe for the behavioral health care manager who's not sure they want to do collaborative care because it doesn't seem right. Or the site consultant who's like, I don't even know how you do that. What? You don't see the patient? Right? Like this is what you see regardless of which role someone might be in from a discipline standpoint, or the MA that's like, okay, yeah, that's something else to do. I don't want to know about that. I'm not helping with referring no patients. That's something else to do. The importance of having those champions and leveraging them in those different formats, even for large advocacy reasons. When I hear about states who don't want to do, I know Patty jumped off, and I meant to say this when she mentioned the comment that some states just never want to do. It's interesting when she starts saying, well, the state over here next to us is doing this, and the state over here on this side of us is doing this. You'd be surprised how often the states don't, though, want to be the last one left behind. So there is this competitive nature from that standpoint that also does happen on an advocacy state level between states.
Daniela, to your point also, the experience is just so important. It's so much easier to help somebody understand through the experience. I can say that's something I'm right now working with the American Medical Association, me and Jen on here to revamp their IBH toolkit. And it's really hard to explain this stuff in a way that's engaging because so much of it is it when you see it. And so people will like roll their eyes with the elevator speech, even if it's like perfectly tailored to that person. Nothing is like you experience it, it helps in your day, and now you can't get enough of it and you use it more and more, and it gets better as you use it more and you build more relationships. It's so difficult to help people understand, like, how do you explain what something is that universally should be, what is a relationship? I mean, like, there's so much of this that it's hard to explain, comparing to living it when it's done well.
Yeah. So we are at time to give you all time to transition, hydrate yourselves, go to the bathroom, all the things you need to do. We appreciate you all coming. Again, another plug for the conferences coming up in Raleigh, if you're able to travel and willing to travel in Raleigh, North Carolina. So that information is up and ready for you all. Our next SIG, we do have some guest speakers. I cannot though remember off the top of my head what the topic is. Laura, you might remember before me, but
I
I
got
don't
it.
do
I
you
got you,
remember?
Monica.
Okay,
We're going to
because I'm
be
like,
having exciting discussion on AI and applications for CoCM. Um, Also, digital technology, digital therapeutics for mental health with applications potentially for CoCM. I have confirmed we will have remote focus and Emma Care. So, being able to hear about gamification AI and how that's working for their collaborative care model development. So, super exciting to hear from them. And Monica, I think you had reached out to another person. Have they confirmed?
yeah, they have not confirmed yet. They were looking at some dates, but many of you may know that there are billing codes that are available. This is again beyond just collaborative care, but billing codes there are that are available for approved vendors regarding digital And so one of those vendors who is on the approved list is going to come just to talk about what their service is, what it looks like, how it taps into the work that we're doing with collaborative care.
So exciting. I don't know a huge amount about some of these areas as well. I'm really excited to learn about it and expand my understanding.
Gotcha, gotcha. All right. Well, you all have a safe holiday weekend if you're celebrating this holiday. If not, enjoy just the extra day off. Hopefully you have the day off. And we will see you all next month.
Thanks, everybody. Till next month.